This month's program continues our exploration into the connection between diabetes and heart conditions. If you missed our other two, you can find them online. October's session on lipid mythbusters, supplements, and cardiovascular risk is on our YouTube channel and also part of a series on the Mended Hearts National website. Our December program on diabetes type 2 in your heart introduced the Reuters news video called COVID and Diabetes, How the Pandemic Laid Bare America's Diabetes Crisis. We watched 3 stories of people with diabetes type 2 and learned that 2020 had a 17% increase in diabetes type 2 patients and that they were getting younger. The 2 short videos from the National Institute of Diabetes and Digestive and Kidney Diseases told us that heart disease is the #1 killer of people with diabetes. We heard patients talk about what they were doing to manage diabetes and keep heart healthy with diet and exercise, but no one talked about their A1C. During the American Heart Association's Q&A phone line called Lifestyle Choices to Protect Your Heart, Ask the Experts, which anyone can get on and listen to, we listened to Dr. Melissa Young, who works with veterans in the Salt Lake City area, answer 6 callers who asked about their A1C numbers and metformin, and there was some confusion around the latest medications available. Well, today we are joined by someone who can pick up where we left off and help us understand some of these newer treatment options for diabetes type 2. Dr. Tang is an ambulatory care pharmacist at Kaiser. She specializes in diabetes management and is a member of the chronic conditions management team. She's from Southern California, got her doctorate at USC, and further training at Stanford and Kaiser Permanente. Dr. Tang joins us today to talk about the drug-specific and patient factors for these new anti-hyperglycemic drugs. And you'll get used to these initials, GLP-1 and SGLT-2. The American Heart Association wrote on their website, in the last few years, newer anti-hyperglycemic medications, which are the GLP-1 and SGLT-2, have not only helped reduce blood glucose levels, but have helped prevent heart attacks, heart failures, and strokes, and slow the progression of chronic kidney disease. So take it away beyond metformin. Dr. Tang.
Oh. Hello, everybody. Can you hear me?
Yeah.
Yes.
Yes.
You might see my eyes pivot from 2 screens because I'm working off of a dual monitor. It's just easier on my eyes. I have a history of eye strain, so I don't mean to ignore you, but it seems that way. That's why I have two screens going on here. Okay, audio is good, video is good. I'm going to start sharing my screen now. Let's get going. Okay, let's share that screen. Okay. Can everybody see my screen okay?
Yes.
Yes. Okay, I'm going to maximize a real estate, like Laura would say. There you go. Okay. So I have the tendency of speaking really fast. So I'm going to try to slow it down. And even if that's too fast, just tell me to slow it down. I have no problems with that. So today's topic is essentially about what are my treatment options if I have type 2 diabetes beyond metformin. Metformin for a long time has been the standard of care and is still the standard of care when you combine it with diet and exercise. So we're going to branch a little bit beyond that and talk a little bit about the other options out there. Okay. So I have no disclosures to share. A little bit about myself. I do practice at Kaiser Permanente as an ambulatory care pharmacist in primary care, but my focus is diabetes. specifically type 2 diabetes. I manage patients, mostly telephonic. Sometimes I might see them in person to try to optimize their medications. Okay, what are we talking about today? I have one objective and one objective only, and that is to guide you through if I have type 2 diabetes, whether new, or if I've lived with it for 20, 30 years, how does my doctor or doctors pick the medication for me or the number of medications for me? What is their thought process behind selecting it? Well, you'll see it has to do with the different properties of the medication, and it also has a lot to do with the patient themselves. Like, what is their medical history? Did they have a heart attack before? Or did they have a stroke before? How old are they? Are they capable of safely giving themselves insulin? What is their family support like? If this is like 10 plus medications, are they going to be able to handle this? And also cost. Cost is a huge thing, like affordability factor is also something we consider. And we're going to go through all of that more systematically in the next couple of slides. Okay, so how does my doctor pick the medication for me? That's the objective. A little bit about diabetes. I'm going to abbreviate DM2 to represent diabetes type 2, because there's type 1, there's even a type 1.5, but we're going to focus on type 2, which is the most common. And what is type 2 diabetes? Well, it's the most common type of diabetes, and what it means is your body is not using insulin properly. And insulin is an important hormone to keep your blood sugars in balance in your body. So if your body is not using insulin properly, then your blood sugars are going to fluctuate. They're going to be high. Okay. How do we manage type 2 diabetes? Healthy eating, physical activity are the pillars. Medications are helpful, but they're also important as well. And if you've been living with type 2 diabetes, A1C test is probably not a stranger to you. It's a measure of how well your blood sugar is controlled over the last 2 to 3 months, depending on how fast your red blood cells turn over. Okay, so whether you've eaten the day of or the day before, this test is not going to change very much because it's an average. It's looking at what is my blood sugar over the last 2 to 3 months, not the last couple of days. I have patients tell me, well, it must be like the cake or like the candy, the overindulgence during the holiday that makes my A1C so high. And I have to explain to them it's an average. So it's looking at your performance over the last 2 to 3 months. So what's happening the couple of days before, even the week before, is not going to change the score very much. Okay. So statistics, let's jump into that. So in California, over 3 million people, or about 10% of the adult population, have diagnosed diabetes. That's 1 out of 10. Just let that sink in. 1 out of 10. If I line 10 patients, one of them has diagnosed diabetes. So that doesn't account for people who are undiagnosed. So I think this is an underreport, but let's just take it at face value. Well, what about the people whose blood sugars are high, but not high enough to be diagnosed as diabetes? That's what we call pre-diabetes. 1 out of 3. 1 out of 3. And when we dive into the medical expenses, just for 2017, and this is again California data, direct medical expenses, it's almost $30 billion. And if we break it down further, including hospitalizations, prescription medications, and the medications to treat diabetes itself and the supplies, accounts for about 15%. So that's almost 20%, 1 out of 5. Okay, so let's get into the bread and butter here. At the very top, so the orange, efficacy, hypoglycemia, blue, and weight change. So I'm trying to direct your eyes here to the very, very top, okay? All of these factors are considerations I consider, and other providers will too, to decide which medication should I pick for my patient with type 2 diabetes. Seems very busy, but I'm going to break it down. So efficacy, what does that mean? How well does this medication work to lower my A1C? That's what efficacy means. Think of it as effectiveness. How effective is this medication? They'll break it down between high intermediate effectiveness. And then the next blue box here is hypoglycemia. What is the risk of this class of medication in dropping my blood sugars too low or too dangerously low? So far we have two factors to consider, right? How well does this medication work, or the efficacy? What is the risk of this? Let's just use metformin as an example of dropping my blood sugars. Not very high, the risk is not high at all. What about the impact of these medications on my weight? Is it going to cause weight gain? Is it going to cause weight loss? Is it weight neutral? That's one consideration. So CV effects. CV stands for cardiovascular. Think of it as your heart, okay? So they further break it down between ASCVD and HF. What does that mean? ASCVD means, what is this medication's impact in reducing my risk for a heart attack or stroke? What is this medication's impact? And HF stands for heart failure. If I have diabetes, I also have heart failure. Would this be a better combination for me? Or would this drug benefit me in some way? Would it expand my life expectancy? Would it keep me out of the hospital more often if I have concomitant heart failure? Okay, so far, how well does this medication work? Does this medication carry a big risk of dropping my blood sugar? What is its impact on my weight? Does it have any heart benefits? All right, directing your eyes to the green here. Cost, is it very expensive? How do we rank this? Is this high, low, intermediate? All depends on the insurance. What form does this medication come in? Is it a pill or oral? Is it subcutaneous, which is what SQ stands for? It just means an injection under the skin. All right, the second to last panel, renal effects. We know that uncontrolled diabetes, especially uncontrolled for a long time, can really stress out the kidneys. So if we're taking a medication to lower our blood sugar, it's intuitive to ask, well, does this medication have a special kidney protecting effect? Like, does it have a special heart protecting effect, like I talked about earlier, the cardiovascular effects? And then additional considerations, which is the blue box here. Some medications might have unique side effects. I'll take metformin again as an example. It's notorious for potentially causing nausea, vomiting, and diarrhea. That's a unique, side effect to metformin. And the follow-up question is there a way to minimize, these side effects? Because it's always a trade-off, and there is. I'm going to use this example here. Do you see my arrow just circling around this box? You can follow, like right here. Yes, because SGLT2, you walk all the way at the end, additional considerations. So this class of medications called SGLT2 inhibitors, well, what are some unique things about it? Well, for some people, it can cause genital infections or urinary infections. This medication can also cause your blood pressure to drop too low. So these are special additional considerations unique to this class of medication. Okay. So I said a lot of things. So essentially the very, very top are all the considerations and nice colorful boxes that goes through my mind when I pick a medication. What is the best fit for my patient? And then on the left hand here, all the red, metformin, SGLT2 inhibitors, GLP-1, RA, think of it as just a class of medications. Metformin is a standalone medication. There's really no other medication in that class or that family. Whereas SGLT2 inhibitors, think of that as a class of medications or a family of medications. And in that family, there are members. Okay, so that's why you'll see, medications like empagliflozin. Another name for that is Jardiance, or canagliflozin. Another name for that is Invokana. That just means they belong to the same family. Okay, so this is basically the same thing. except there's just more classes of medications. DPP-4 inhibitors. This is a very long name. I don't even know how to pronounce it myself some days. So I'm just going to abbreviate them as TZDs. Thiazolidodiones, very long. Sulfonylureas is another class of diabetes medications. And then, of course, the insulin. Okay. I'm going to review again. These are the factors that I consider when I pick a medication. Efficacy, how well does it work? Low blood sugar risk, impact on weight. And then to the left is just a class of medications. All right. This is also a very busy slide. It essentially says the same thing, except there are arrows. Some people might, follow that better because there's a flow chart. If this, do this. If that, do that. So I'm going to go through it also very, very slowly, and you have lots of opportunity to ask questions in the end as well. Let's start at the very top. Okay. Gray box, first line therapy, meaning the medication that you should pick first for a patient with diabetes depends on comorbidities. That means what other health conditions does my patient have? You got to also consider patient-centered treatment options or treatment factors. For example, are they frail? Do they have arthritis? Are they going to be able to drop insulin okay? Right? These are patient-specific factors. Cost, those are all the considerations need to be met. And then, of course, diet and exercise. That's always, pillars. So going down on the left-hand side, red box, do they have high risk for having a heart attack or stroke? Or do they have heart failure or HF? Do they have kidney disease, CKD, right? Is everybody following me here? The red box to the left? Red box to the left?
Yes.
Yes.
Yeah.
Okay, thank you. So say the patient does have, those risk factors for having a heart attack or stroke, or they have heart failure, or they have chronic kidney disease. So what you would do is pick one of the medications to the left. So right here, ASCVD indicators of high risk. Let's just say my patient, Mr. Jones, he's 74, he's had a heart attack before, and like heart disease runs in his family, like his mom had a stroke at a very young age, for example. Then I would pick an GLP-1, or I would pick a SGLT-2 for this patient. Now, this is assuming this patient has already optimized their exercise, they're eating really well, they're on Metformin. Okay, what medication should I pick next for this patient? Regardless of what their A1C is. It's terrible, it's great.
Oh, may I ask a question about that?
Yes.
So I saw in the gray box above that that it says recommend independently of baseline A1C.
Yes.
Either that or the individualized A1C target.
Yes.
So if my A1C is not very high, I might actually get benefit from some other drugs as well as metformin.
Yes, exactly. Say your A1C is well controlled, you're on metformin. Should you still pick one of these medications? And the data says yes, because it has heart benefit or kidney benefit.
Okay.
Even if your A1C was really, really high and you're on metformin, should you pick another medication for the kidney benefit or the heart benefit? And it's yes. That's why we're going through this algorithm.
Okay. Well, no, thank you. I just, when you said it didn't matter what their A1C is, I was like, oh, okay.
It does matter, but it also doesn't matter. It matters in terms of like, say your A1C is, and again, your A1C is a measure of your blood sugar control. If it's well controlled, right? And you have a history of dipping into those lows, then maybe if I were to start a GLP-1 or an SGLT2, then I would be careful and maybe reduce the current medications that you're on to minimize that risk of a low blood sugar. I'm trying to use these medications to give you heart benefit or kidney benefit.
Okay.
But I also have to be mindful that yes, it can drop your A1C. Not the best, but that's why we're using it for like a different reason.
Okay. Thank you. No, that's very helpful.
Yes? Okay. Stop me with questions. I'm not sure if I should clarify as I go along or save to the end. So I'll just pause here again for if I lost anybody or I should go back anywhere. Feel free. Stop me.
This is very interesting, actually.
Yes, it is. So it really is, because before, historically, we were aiming for A1Cs, right?
Mm-hmm.
Got to be less than 7 or got to be less than 8, maybe more frail patients, maybe less than 9. But now it's like, well, can you give me extra benefits? I know I'm at risk for like a heart disease. I'm at risk for like kidney injury because my blood sugars historically is high. Can you do more for me? Is basically the rationale of picking like a GLP-1 or an SGLT2 inhibitor. I'm just going to give, so GLP-1, a very popular one is Ozempic, right? Just think of that as like your model medication of that class. Think of GLP-1 as Ozempic.
Okay.
Think of SGLT2 as like Jardiance. Remember when I went back here, this is just like a class of medication. And in each class, there are members of that class of medications that has heart benefits, specifically in heart failure or specifically in preventing a heart attack or stroke. Some of them even have kidney benefits. But the key thing here is not all members of that class have that heart or kidney benefit. Keep that very, very, like, it's not a class effect.
Okay.
And the reason why I use Ozempic for GLP-1 and Jardiance for SGLT2 is because those have shown heart benefit and kidney benefit.
Okay. So when the news tells us that most people with diabetes die of heart problems,
Yes.
this medication is supposed to help with heart or kidney things.
Yes. Think of it that way. Reduce your risk. Nothing obviously is like bulletproof, but enough information where the American Diabetes Association, which is where this chart comes from, is recommending one type of medication over the other.
Okay.
There used to be less of a preference, but now there's definitely more of a preference, cost aside, because of the heart and kidney benefit.
Well, and just, I'm sorry, just to make sure I'm understanding this also, when you went through Metformin on this, because that was one of the questions that was asked, when we were listening to the users talk about it. They said, well, can my Metformin, is that good for my heart and liver also? And the answer was not as much as these other drugs. Was that useful? Was that correct?
So Metformin is an old medication.
Yeah.
And back then when it was studied, the landscape was different. The FDA didn't require new diabetes medications that come to market to test for extra benefits. Okay. But if you look back in the data, there is some data that says that it does have the benefit of protecting your heart, but not as strong as like like Jardiance or Ozempic. But that's also not fair because they weren't scrutinized, to the same degree for approval back then.
Okay.
So mixed. I would say Metformin is mixed. So that's why when you look at Metformin here, cardiovascular effects, it says ASCVD, potential, heart failure, neutral.
Yeah.
But if you move down to say like Jardiance here or the GLP-1s, it's getting marks in these little boxes. But for Metformin, it's like maybe.
Okay.
Okay.
Thank you. No,
Yes.
that's very helpful because I didn't understand why people were moving on from metformin, when it wasn't about their A1C. And it's because that even with metformin, it's not doing anything for their cardiovascular problems. And these would.
That is true. That's why when you look at this treatment flow at the very top, first line therapy, it says consider patient factors, but also management generally considers metformin, because metformin is still our go-to. It's not like we're putting metformin aside and pushing these to the forefront. These are too new to really be first line. It's usually diet, exercise, metformin, been around for a long time. It works well. It's pretty safe. And then now we're like, okay, if you have heart condition or a kidney condition, what else can we add on? Not so much for the A1C benefit, but for the heart and kidney protection.
Got it. Okay. Yeah, thank you. Because I just, they say that this heart conditions are what kills diabetic patients. And like, well, wait, my metformin is supposed to solve that. And so now they've tried to help the heart patients that also have diabetes.
Yes.
Okay, thank
That's
you.
really where those medications fit in. And all the text aside on this page, if you break it down very simply, it's on the left. If you have a heart condition specifically that puts you at an increased risk for like another stroke or a heart attack, or you have chronic kidney disease, go with the left panel. Pick a GLP-1 or pick an SGLT-2. On the right is if you don't have any of these, right? So this is why that red box goes to none. None.
Got it. Yeah.
Then it points down here. Then, okay, so my patient is on metformin. He's eating healthy. He's exercising. He doesn't have any heart risk factors. His kidneys are fine. What else can I do for him? Well, it depends or what medication should I pick for him, I should say. It depends what you prioritize. Are you trying to minimize the risk of a low blood sugar in this patient? That's why there's an arrow that goes, is your priority minimize low blood sugar? Is your priority not causing weight gain for this patient? What if this patient is, body mass index is really big and they're overweight, for example? Then maybe in that patient, don't pick these, don't pick those. Or are you prioritizing cost and access? Then you would go down this path here.
Okay.
Okay, I'm going to pause here. Questions? I know this is a lot.
Hi, Sally.
Hi. Hello.
So,
Well, now I certainly understand more about the difference between Ozempic and Jardiance, because those are probably the ones that if you watch television, you see all the
segue.
time. Oh, nice.
Segue. So the question, Steve, I understood was like, what's the difference between Ozempic and Jardiance? Did I understand that correctly?
Yeah. Yes. Now I think you've explained it very well, and I understand it better. Yeah. Thank you.
Sure. On a very broad, what's the difference between Ozempic and Jardiance? First, for a convenience factor, I personally like that it's a tablet, so that my patient doesn't have to inject. But some people, they don't care, and they can get past the side effects of Ozempic, and they can get past the injectable format of it. Then Ozempic may be a good fit for some people compared to Jardiance. Now that's just a patient use factor, right? One is pill, one is injectable.
Right.
Cost aside, they're both going to be more expensive than, say, metformin, because they're newer and they have these bells and whistles with heart protection, kidney protection. And then I got to ask myself, well, how good is it in lowering an A1C? Like, are we talking about, let's just say the goal of A1C is less than 8 for this patient, and his A1C is 9. I'm trying to bring him to 8. So I'm asking myself, well, which one is going to lower the blood sugar better? Then I look at this efficacy chart here. SGLT2s, let's just pretend that's Jardiance. GLP-1, let's pretend that's Ozempic. The SGLP-1 as a class is a little better at lowering the A1C because it says high, right? Because high. The Jardians, for example, GLP-2 inhibitors, efficacy or how well it works is intermediate. That's another consideration. If Mr. Jones is prone to a low blood sugar all the time, especially overnight, well, am I going to pick the Jardians or am I going to pick the Ozempic? It looks like as a class, risk of low blood sugar or hyperglycemia is low for both, which is great. Weight, look, they can both potentially help with weight loss. Yay, people love that. Then you got to get into the nitty gritty. Well, Ozempic, how much weight loss? Jardians, how much weight loss? That's how I would go about picking, which one would be a better fit for my patient. That's just examples, not exhaustive. Victoza is another one that's popular. It's the same family, as Ozempic. Victoza are in the same family. It's also an injectable. Something else to consider is Victoza or injectable medications in general. There may be different dosing. So some of them may be daily, some of them may be weekly. Some people might like weekly because you don't have to think about injecting every day. But then some people like daily because it reminds them there's a pattern. It's easier for them to remember. So it depends on the person whether weekly works better or daily works better.
Yeah, Dr. Tang, I think we have another question.
Question, yes.
Rena, is that you asking a question?
No. Oh, well, I did want to clarify how I can get a copy of these slides as well as the previous programs, because I'm not clear on that.
Oh, well, I've put a copy of Dr. Tang's slides in the chat. And if you click on it, it will download it.
Oh, nice.
And
Yes.
Okay, how do I get to the chat?
are you on your phone?
Yes.
Aha. Well, I tell you what, I can send it to your email.
Thank you.
I'll do that. And I'll send you
Okay.
I'll send you the URL for the other shows. How's that?
Okay. For the previous shows and
Yeah, the ones on
the slides for this show, you send it to the email.
yes.
Thank you, because I'm not on the computer.
Okay.
More questions? Well, I have a question. And the questions I often get are like, why do we care so much about diabetes medications with heart benefits? Why don't we just care about the A1C? I don't know if anybody remembers this medication called Avandia or rosiglitazone. It's been discontinued, but that was the medication that kind of set the FDA off because people who are on that medication, they seem to not do as well heart-wise, especially if they had heart failure.
Oh.
Well, what we learned is that class of medication can cause fluid retention, and that's not good for our heart patients with heart failure because they're fluid overloaded, right? It can make the heart failure worse. So I think that's what prompted the FDA to, in their checklist of approving medications, okay, is this decently good at lowering your blood sugar? Are there any dangerous side effects that we need to consider before we approve this drug? And also now, well, because there was this other diabetes medication that caused heart problems, can we at least make sure that this new medication doesn't cause heart problems? So that was added to the FDA's list of like things to check off. And then it kind of, very naturally, if you're able to show that you're not at least causing problems to the heart, can you help And that's probably why there was another list of things to check off for the FDA when you're bringing a new drug to market. That I think that was the evolution of, you know, tell me if your medication helps my patients with heart failure or kidney disease, things like that. So that's a question I often get asked when I'm giving lectures to like pharmacy students. They have that curiosity of why do we care? Like, what was the history of this?
I don't, Dr. Tang, I don't have a question, but I do have a comment. I mean, now I understand a lot more when I'm looking through the channels and I see the commercials for Ozempic and Jardiance. So from that perspective, it's been very helpful. And as I'm thinking about that, what I see on the commercials is they really don't, to me, it's totally a play towards diabetes patients as opposed to, you know, I don't recall that they mentioned that in addition, this might also have benefit to heart patients. So you know, you know, it's not a question, but you know, I just kind of wonder out loud why they don't use that in their marketing as well, because of, you know, the correlation. And maybe they just want to avoid, you know, over promising or something. But anyway, that from now I understand those medications a lot better and how they, you know, I think their benefit is a lot broader than certainly I understood.
Yeah, I had my suspicions in terms of why they do that. I think the net of casting in diabetes patient is way bigger.
Oh, true. Yeah.
The heart condition. And if they only have like a 30-second run of it, I would probably push the diabetes part if that's like your primary like use for it, right?
Sure.
Because
if you could take us back to the pictures of the boxes.
Yes.
If you notice this, it says on the Victoza reduces the risk of major cardiovascular events.
Interesting. Okay. Yeah.
So they've got it at least on their is that from a website maybe?
Yes, I went directly to their website just to see what's out there. I check out their website once in a while because when they do these studies, initially it's for like patients with diabetes. And then there's like a follow-up study that asks the question, okay, your A1C control is pretty good. Do you have heart benefits or kidney benefits? And then they'll add on that additional like claim later on. And who knows, maybe later on there's going to be more. Like, I think like the third line might be like reducing weight, because as a class, medications like Ozempic and Victoza has, from the weight reduction part, it's like one of the best I've seen in a long time. It's comparable to bariatric surgery.
Wow.
It's better than some of the approved medications for weight loss. Let's just say 5 kilograms is like good. Some of these can go up to 15 to 20 kilograms, I believe, for some patients, which is substantially more.
How many pounds is that?
Wow.
A lot. Enough.
Yeah.
Don't quote me on the 15 to 20 kilograms, but I think it's substantially more than standard, which makes them attractive, right? Because patients with diabetes, what else do they tend to have? You know, that's a comorbid condition like high blood pressure. They tend to be more overweight, right? So this is like great because it fits. You want the blood sugar to be well controlled. Some of these medications can help with weight loss, and it can improve, you know, satiety, so people feel full longer. And I think that's why the weight comes off so well. So it's almost like a dream medication in terms of like what it can do for me. But a limiting reason why people wouldn't use Ozempic or Victoza is like they can't tolerate the side effects, which is nausea, vomiting, diarrhea. And that's limiting. That's known. But if they can get past that, it tends to get better. But that's usually why I would stop a patient on Ozempic or Victoza, is if the nausea is just terrible and they just can't get through the day. I hope
I remember on one of the commercials, I don't know if it was an actual patient or an actor, said that for years they've told me to take my medication, which made me gain weight. I think that was metformin, and now I've got a medication that will help me lose weight, which is what they told me I needed to do. So the medication was finally helping. They were trying to make that point.
Yes, and it brings me back to this point is, what are you trying to prioritize for this specific patient? Is weight gain or weight loss like at the top of their list, and that's what's going to prohibit them from taking their medications that help their blood sugar? Yeah, maybe pivot towards one of these medications, you know, the SGLT-2s or the GLP-1s. Metformin, on paper, you know, weight-wise, there can be some loss or at least neutral, but every patient is different. So if they come back and they tell me, you know, I noticed more weight gain with this, I would usually be suspicious because from my experience, it helps weight loss. But it's definitely not as substantial as insulin and medications like glipizide. Those are top tier weight gaining medications.
Big weight gains, yeah.
Let's go back to the questions. Questions or comments? I know we're getting to the 11 o'clock time, and I want to respect everybody's time. I won't keep you for too long. I'm really excited about this topic, so I go on and on and on and on.
Thank you. It's wonderful to have our questions answered, and I'm so glad that you can talk to us like patients instead of like interns that know all the abbreviations and shortcuts in how to explain things. So I thank you for explaining.
Oh, of course, of course. I know it can be a lot, so I try to break it down as much as I can, and feel free to, you know, download these slides, use these slides. You can feel free to also email me if there are follow-up questions. I'll be happy to try to address that.
Thank you. May I give them your Gmail?
Yes.
Okay.
Yes.
Thank you.
Yeah, no problem.
Well, that's wonderful. Any questions?
The Gmail?
Oh, do you want it now, or I can include it, Rena, if I can include her Gmail.
If you send it to me, that's okay. I can get it all at once.
Okay, I'll do that. All right. Okay. Well, if you want to stop sharing your screen, and we
Sure.
will see if there's anyone else that would like to.
Let me share. Oh, there you go. Stop sharing.
All right. Well, this has been a wonderful thing, and thank you so much for hanging on with us after that proposed strike kind of bumped you off our schedule. I'm so grateful that you could come back.
Yes, yes.
Thank you.
Excellent
I hope
program.
this was helpful. Feel free to message me if you know you have a specific question to you, or if I
Okay.
lost you anywhere. I'll clarify. It's not a problem.
Okay.
Okay.
All right. Well, thank you, and thank you everybody for coming for this wonderful talk. And see you next month.
Great
Bye.
stuff.
Thank you, everybody.
You,
Thank you for
Dr.
having
Thank
me.
you.
Shout
Thank
out
you.
to Laura for
Bye,
helping
Dr.
coordinate, and also Bill for
Dr. Tang.
Thank you.
Wonderful.
Bye.
Thank
Take
you.
care,
Very
everybody.
good.
Dr.
Good
Tang.
meeting.
Thank you. Thank you.
Bye-bye.
Thank you.